That's our chair. I'm really grateful that longtime colleague and friend, Dr. Dylan George, is willing to come up from Washington, D.C. to Providence to come speak to us today. I asked Dylan to give you a little bit of an overview of the many turns and twists in his career, but he is currently the director of CDC's new Center for Forecasting and Outbreak Analytics, which doesn't really capture the fact that the creation of that center and the whole idea for it and the vision for what it could achieve credit goes to Dylan. He had been leading efforts in the government to make that center a reality. It became a reality, and now he's building a team. It's just really just to watch. Like, you go from just like idea, like, hey, there's this, wouldn't it be crazy if, to creating a full-fledged center that's now everybody's looking to. So really, thank you for coming. Thanks for sharing that.
So I think I'm live. You can hear me right now? Yeah, okay, great. It is an absolute pleasure to be with you all today. It's my name is Dylan George, and it's just to give you a little bit of background on who I am. So I I was a graduate student at one point and looking at biodiversity and ecosystem science. So I was really interested in plants and what they do in terms of enabling how to circulate nutrients in the atmosphere and moving things around. And as a very elaborate excuse for finding a reason to go backpack in Canyonlands National Park in southern Utah, I did a master's degree looking at microbiotic soil crusts and how they would actually enable carbon fixation and cycling carbon going forward in different ways. But to do all that research, I had to go back not Southern California in Utah and hang out there for a long time. So that's kind of where I started in my academic career, thinking about that. But then I ended up at the National Science Foundation because my wife she wasn't my wife at the time, but she took a job at the World Bank. And so I had to go to DC to see about a girl and figure out. I thought I was much more persuasive in person than I was long distance. So I went to DC, ended up getting a job at the National Science Foundation. And that's when I saw this program that just started. It had just started. It was called the Ecology of Infectious Diseases. What was required in all of these proposals was you had to have a mathematician or a mathematical model associated with the proposal to understand what the dynamics of the infectious disease in that system was. And that was the unifying principle, because at the time they were trying to bring math and biology together in a much more robust way. I was a junior person that helped review the proposals that were coming in, and I just got so fascinated with seeing all of those proposals and how they were using theory to understand the world, and then to go out and try to compare observation against that theory and see how well the theory behaved and where it worked and where it didn't work. And so through the course of helping at the National Science Foundation, I actually then went to decided to change my career completely and think about it. It's like, oh, I want to do this versus what I was doing before. And so I went back to get my PhD, but this time I was focusing on infectious disease dynamics and how to better understand how diseases move through different populations. So I got my degree working on developing mathematical models for understanding how plague moves through prairie dogs, because plague kills off almost all prairie dogs that it comes in contact with, pestis. So the big question becomes, it's like, well, if it kills all the individuals, 99% of all the individuals that it comes in contact, how does it stick around? Why do we still have plague in Western United States, and why does it stick around in different ways? So I put together a handful of models to explore hypotheses as to why that would allow to happen. Similarly, I did some work on rabies in bats. How does rabies persist in bat populations? And there were some folks that were working on that in Fort Collins, Colorado, and so I got to hang out with them, which was very, very fun. But then all the things that you learn about how to model in wildlife populations are very applicable to how you understand how pathogens move through any population, hence human populations as well. And so from there, I started working I ended up working for the Department of Defense, trying to help them understand how to use mathematical models to understand how to keep when we put forces into any particular geography, they need to understand what the infectious diseases are that their forces will encounter, such that they can actually meet their mission and do what they need to do. Because if we insert troops into a particular place and they all become susceptible to malaria and can't do their job, that's a bad move. So we need to think about how to protect them to do their job. So we came up with a lot of models to help think about how to protect the force and how to actually incorporate that into going forward. That was super fun, very interesting. And then I worked for, then after that, I ended up going to work for the Biomedical Advanced Research and Development Authority, BARDA, at HHS. The cool thing about that job was we were able to actually use modeling to help us understand, it's like, what would be the Armageddon scenario? So nuclear detonations, a biological attack, a pandemic, how bad could it get? And then what do we need to put into the strategic national stockpile to make it much more manageable? Hence, the modeling that we did there helped actually determine what was stocked in the strategic national stockpile so that we could actually deploy that in a time of crisis. The strange thing about working for the Biomedical Advanced Research and Development Authority, though, too, is that as we were doing, I had to do a lot of, I was in a lot of briefings about nuclear detonations and over a city. And so you don't look at buildings the same way you do after you've been in a lot of those briefings. It's like, you think of them as crushing potential, projectile potential, or just, yeah, you kind of wonder, it's like, do I want to be hit by the projectiles, or do I want to be crushed by this? I don't know. And I think being vaporized would be the best way to go, to be quite honest.
And inward.
Exactly. So, but yeah, no, those are, but those are fun times because it was very interesting to actually develop different models for different places. And to try to see how to use modeling to inform very important decision making going forward. That was about 2014, 2015 when Ebola hit. One of the things I did during that phase is I brought together modelers from across the federal government and also academic modelers to actually say, it's like, okay, how do we actually understand what's happening with Ebola dynamics and what is the risk to the homeland? And how do we actually use modeling more effectively to inform decision making to help out with that particular response? One of the things that was really interesting about that situation was trying to understand, that was one of the very first times where we actually used forecasting. We used forecasting to anticipate what was happening in West Africa with Ebola. And it helped us actually inform on a handful of clinical trials because we were one of the first groups that were starting to say, it's like, hey, you're going to see a downturn in the number of cases, which is a good thing. It's a great thing. But it also means if you're going to put clinical trials into play to understand some of the value of these therapeutics, you need to change your clinical design to get more power much more earlier in this clinical trial and how you're moving forward. And so we had a really good series of discussions about that and actually increased how we were actually able to use clinical trials much more effectively to get as much information off of them as we possibly could going forward. That was a really great example of how we were doing. But my colleague, actually Jason Asher, who I was with at BARDA, that's the first time we ever used forecasting to try to help inform decision makers in different ways. And then I ended up through hook and by crook, I ended up at the Office of Science and Technology Policy in the White House. And from there, and because they saw what we were doing with Ebola, and they wanted that same sort of advice and help at the White House in informing some of the decisions that they were going forward with that. And that's where I met Beth. As many of you know Beth, she taught me a lot about public health in the global context. Also, she was just an invaluable colleague to help think through what we would need in terms of capabilities, what we would need in terms of putting this kind of a center together. And she's been a good colleague and friend ever since. But then I went to the dark side of the private sector after that for a while and worked in the private sector. And then Jen and Beth asked me to come help with the Biden-Harrison transition team right at the beginning going forward. And so that's where we actually revisited this idea of how do we actually stand up this center? And we put a lot of thought into that during those months, and put it together in a couple of executive orders to actually stand the center up and move it forward. And hence, that's why we're here today. And then I, again, got recruited into the CDC, the former CDC director, because they wanted somebody from the outside to come and build a whole new center, a whole new way of thinking, and a whole new way of developing capabilities going forward. So that's a long and tortured description of my ill-spent youth going forward. But the thing that's been really fun about it, and the through line through my whole career, though, has been trying to use analytics or data technologies in some way to either understand or to mitigate infectious diseases in some way. And so there's a lot of opportunities if you have a really strong passion for a particular topic and a particular idea on how to push that forward, how to manage going through and kind of like bounce through various opportunities, because there's lots of them particularly in the federal government. Now, like I said, I work with a team of folks, and we're building the Center for Forecasting and Outbreak Analytics at the CDC. So if you don't remember anything else about this presentation, the main objective of the Center for Forecasting and Outbreak Analytics is this bottom line right here. We're trying to use better data for better analytics for a better response. The better response is what we are focused on. We are a cross-agency capability to actually improve our response options. We are not a siloed kind of organization where we're just focusing on one pathogen or one type of situation. We are trying to, when the CDC stands up a response, what they do is they create an incident management structure, and they set up one person in charge that is making the shots, calling the shots for everything. Then you have the various task forces that report up to that incident manager on various topics. When they stood up the data analytics team or the modeling team, they had to beg, borrow, and steal people from all the existing sorts of centers across the CDC to actually do this going forward. Now, with the Center for Forecasting and Outbreak Analytics, we are the pointy end of the spear. We are the first ones in, and we are the last ones out on a response. We are the ones that come in. You don't have to beg, borrow, and steal anymore. We're the ones that are there right away. Now, we get augmentation from the other centers and how we're doing this, but we are answering that call right away because we're the response organization. So it's better data, better analytics for a better response. Is where we're going to be. Let me see if I can do this. Yep, there we go. So I was on a panel this last summer with Dr. Charles Chima, who is the health official from Sioux Falls, South Dakota. And he actually said this statement. He said, data for action is the vaccines of our generation. Now, to a group like you, of public health folks, who understand the importance and the centrality of vaccines in fighting infectious diseases, it is an invaluable tool. It has changed the way we fight infectious diseases. Can you imagine the COVID pandemic without having that vaccine after 11 months? It would have been radically different in how we would have lost so many more lives. Vaccines are the central way that we're actually doing this. It's a critical tool. Charles, though, he believes data for action can be on the same level, order of magnitude of impact as vaccines. And I happen to believe that as well. I think that even if we are able to be wildly successful with the 100-day objectives of creating new vaccines for future outbreaks, we will have 100 days of a pathogen rampaging through our population. So we need to find ways of actually mitigating that effect. Data for action and helping us understand the risk, communicating the risk, and moving people such that they change their behaviors to not have that risk is all going to be a function of data and how we do that effectively and move that forward. So data for action is the vaccine. That is the motivation of what we're trying to do right now. Now, within CDC, there's a couple different efforts that are ongoing that are intertwined to actually how do we use data more effectively to be a superpower to keep people safe in a time of health emergency. There's a couple interlocking particular efforts right now. One of them you may have heard is called the Data Modernization Initiative. That fundamentally is an effort to increase the interoperability and the speed with which data moves from things like immunization records, from vital records, death records, from electronic health records, from the laboratories to public health, so that we can have that much more quickly. Now, it's for all of public health, not just for outbreaks, but all of public health, from gun violence and seatbelts all the way to infectious diseases in some capacity. So it's a huge undertaking to try to improve how do we actually systematically bring the information in much more quickly. It's a big effort that's going on right now, and that's what's going on there. There's another, you may have heard of HHS Protect during COVID. Why we've rebranded it to Response Ready Enterprise Integration, Ready. It's not completely clear to me. We don't really brand things very well at CDC. So I'll be the first one to admit. But fundamentally, this is HHS Protect. And what this is doing is aggregating, you need one source of truth during a response, during an outbreak. So what HHS Protect does is it pulls from the data modernization, the new data systems, into one place to have that ground truth, that golden source of information that everybody can work from, so you have a common operating picture of what is the situation going on right now. But even if we're wildly successful, where we improve all our data systems and we get them all into one particular place, this is all historical data still. This is all past data. This is where we come in from the Center for Forecasting and Outbreak Analytics. Our objective is to use that information to project into the future what we anticipate is going to be happening with an infectious disease event. I've said this to several of you before. It's like when we drive a car, we don't drive a car looking into our rearview mirror. We look through the windshield. We're looking forward. That's what we need, more tools to help us look forward in an outbreak. That's what the Center for Forecasting and Outbreak Analytics is doing, is we're coming up with tools that will help us think about what's coming next and how do we be prepared for it. And so that's how we're interoperating together, as the data modernization, the Response Ready Enterprise Integration, or the HHS Protect, and the Center for Forecasting and Operating. So we're not the only ones within CDC that are trying to improve data systems, but we're a component part of a broader system. Now, the mission and vision of what we're trying to do is right here. We're trying to empower people to save lives during health emergencies. We're doing that through cutting edge analytics, generate insights that will be more robust than what we've had before. We're trying to accomplish that through 4 specific goals that we affectionately refer to as predict, inform, innovate, and advance. Predict is our ability to deliver the actual analysis and insights. Inform is how do we translate that information for action, which is really hard to do. And so we're going to spend a fair amount of time trying to get better at that. And then innovate. We need to be at the forefront of outbreak analytics. We need to be pushing the frontiers of how we use models to understand infectious diseases. We also need to be at the forefront of technology that is actually using the data much more quickly and being able to provide it in different capacities. So we're going to be spending R&D dollars to actually get better across the board. And then advance. This is we want to be a world-class organization that does this exceptionally well. This is the kind of this is the place where I typically say, it's like, this is where I keep poking Stephen Riley, who's the Director General of the UK Health Security Agency, and has a similar role to what I do in CDC in the United States, where I keep poking him and saying, it's like, we're going to be better than one day. So he loves it when I tell that joke. But those are the 4 goals that we're trying to accomplish going forward. These within Predict, we are going to be focusing on 2 big buckets of effort. One is what we refer to as real-time monitoring, and another one is analytical response. What I mean by that is that real-time monitoring, we're going to be developing a set of tools, minimum viable products, that will be useful for helping us anticipate what's going forward. What we're going to be doing is we're going to be creating tools that will not only help us parameterize in ongoing outbreak, but also continue to stand at the forefront. Before COVID, you could almost parameterize a model and be good with it throughout the rest of the outbreak and everything. We had to constantly be reparameterizing with COVID in the last wave. So we need to be nimble and be able to do that effectively going forward. Forecasts, we're going to be using very similar sorts of approaches to what numerical weather forecasters use to actually anticipate, create a probabilistic statement of what we anticipate will be the trajectory of an ongoing outbreak with for the next 2 to 4 to 6 to 8 weeks or so. Depends on the quantity and quality of model of data rather in our ability to do that. And then also we're going to create what we refer to as scenario projections. This is not really a probabilistic statement about what we think is going to happen in the world, but it's going to be a logical extension of what we potentially think should happen given what we know about epidemiology and what we know about the current state of a particular population. Actually, if you want to see a really good example of a scenario model, I read one this morning. Rachel Baker is in your faculty here. She wrote one in 2020 about what would potentially be happening if you saw, once we released the pharmaceutical interventions, in terms of what you would anticipate would happen with RSV dynamics. Pretty much her model nailed it. It was a great example of what we're going to be trying to do with some of the scenario models. And so, so you kind of have a star in your midst. So it's really good that way. We're going to be developing all of those kinds of capabilities going forward. Also, our other section here, though, too, is analytical response. We kind of need a SWAT team. You know, when Mandy Cohen comes and talks to me and says, I need some help with question X, or when Paul Friedrichs from the Office of Pandemic Preparedness and Response at the White House comes and asks me, I've got a whole bunch of tests, COVID tests, when should I send them out? How do I, what should I think about that question? I send in my SWAT team of folks. They figure out as much as they possibly can in as short amount of time as they possibly can. And then we go in and we brief those particular seniors on what that is. And by the way, it's like the answer to Paul's question was send them out now. So just for your awareness. Yeah. But so we need to be able to do that. Sometimes we can build some really great tools that are going to be turn the crank on. We need on an ongoing basis. Other times we're going to have to actually answer bespoke questions on a particular outbreak and do the best we can with the models we have and with the data that we have at hand. And we need to be very nimble in going forward. So we're going to be able to build 2 different teams that are primarily going to be looking at those kinds of efforts going forward. Now, Inform, you know, translating modeling results to decision makers such that they can actually take action in terms of a policy or implement a particular program is challenging. It's not straightforward. It's very difficult. And for those of you that have worked with modelers before, you'll know that sometimes they like to talk in equations, which is not, you know, what your mother typically talks in. And so it can become challenging. For example, you know, when Silicon Valley Bank imploded a couple months back, it's like, what did that mean for my 401k? I had no idea, none whatsoever. I'm not an economist, didn't make any sense. Going and talking to economist friends, they could easily help me walk through what are the economic principles of what that was and how that would impact things going forward. And so they laid it out very straightforwardly. They had intuition about what that was like. Most of the policymakers that you're going to be talking to are not going to have epidemiology intuition. So you have to be able to put it into terms that they understand very effectively. When I was working, I had the great pleasure of working with the former Mayor Durkin, Mayor of Seattle. In the early part, when I was still working in the private sector, I was working with Mayor Durkin. She had the insight of actually bringing together a panel of expert advisors to help her think through what needed to be done to keep people in Seattle safe. And they had the Institute of Disease Modeling, which was a part of the Gates Foundation ecosystem. They had them actually, typically what they model is things on PEPFAR, things like malaria, hepatitis, HIV, and that sort of thing for low and middle income countries. But they pivoted their whole team of about 20 modelers to just focus on the state of Washington. And they, on a weekly basis, were providing modeling results to Governor Inslee and to Mayor Durkin and to Jeff Duchin, who is the health officer for King County Public Health in Seattle. And Mayor Durkin needed someone to help her translate the modeling insights into political action. And that's one of the roles that I helped her with when in the early part of the pandemic. Translating these results is not straightforward. It's very challenging. And we're building a team right now of people that are going to help us do that sort of work right now. So, you know, if any of you are interested, we are recruiting. So it's, keep that in mind. But one of the things that we've done right here is we tried to create two different sorts of efforts of creating new ways of communicating results. One we call risk assessments, another we call technical reports. One, obviously, they're very cleverly described to one is to help us understand what the risk is, and the other one is giving more technical details for more modelers. So, but these were new ways of actually communicating within CDC. We were very proud, particularly of what we did during the Mpox outbreak. We put out like 5 or 6 of these technical reports to give people an assessment of what was going on during the Mpox outbreak in the United States. And it was really very helpful to the various states because first we did it at the national level, then we did it at the state level. It was an opportunity for us to actually engage with the states in a very unique way, better understand what their data were, and then also help them understand, it's like, well, based on the data, if these are the data that are actually true, and we both agree that they are, then this is the logical conclusion. You're growing or you're holding steady. If you're growing, what are you doing? And is that sufficient? Do you need any additional resources? That was very useful discussions that we had with our colleagues at the state level during the Mpox result. And these are just new ways that we're trying to think about that going forward. If you type into, you know, like CDC COVID forecast right now, you'll see figures like this pop up eventually. If you have the temerity to go through government websites, which can be really challenging, but you will eventually get to this. What that is showing you is, you know, the forecasts for hospitalization for the next handful of weeks. We've been generating for those for the last handful of months. And also the interesting thing that in just recently as well, we started doing this for influenza as well. So if you type in influenza CDC forecast, you'll start seeing this pop up as well. The thing that's really interesting about that, and if you've been watching this for a while, you'll say, it's like, well, haven't I seen forecasts on the CDC website for a while for influenza? It's like, actually, yes, you have, but they haven't been generated by the CDC. They've been generated by academics that contributed them to the CDC. So this is the first time ever that the CDC itself is generating those internally and putting those out. And so it's a major milestone that was crossed right there in terms of, but that's predict, inform. Oh, and another bit that we just did recently is we did this for the respiratory season that we're trying to confront right now, where we're trying to think about is like, well, how do we navigate influenza, COVID, and RSV, and what is the hospital burden going to be for the United States right now? We took I don't know if it's a bold or foolish step, but we took it where we were trying to actually anticipate how much hospitalization burden would we anticipate over this whole season. I will be the first one to admit you need to be very humble about this because it is very challenging to do for any one of those pathogens. Trying to do it for all three, like I said, may be folly, but the reason that we did this is because we wanted to help hospitals and our healthcare system understand what was the potential burden they should be expecting over the handful of months coming forward, and how prepared are they for that expected burden. Now, we're obviously always learning more. We're always trying to understand more about each of these pathogens. As we learn more, we update our assessments. But really what this is coming down to is based on historical data, based on modeling results, and based on expert elicitation, we came up with an assessment that was essentially saying it's like we're anticipating about hospitalization burden about like what we saw last year. The other aspect of that, though, too, is that it's the hospital burden that we're experiencing now in a respiratory season is markedly higher than what we experienced pre-COVID. So we are in a new world. And for some people, realizing that we have 3 major pathogens causing respiratory illness versus 2, before COVID, we had flu and RSV. Now we have flu, RSV, and COVID is still generating a lot of burden in hospitals. And for some of our state health officials, just making that statement helped them realize, oh, I've got to go talk to my hospital system and make sure they're ready and make sure they're ready to go. So A handful of state health officials have been really grateful that we did this analysis, as straight, kind of as simplistic as it was. But that's another idea of where we're trying to go as well. Innovate, it's like we're trying to establish new ways of doing business, trying to develop new methodologies, trying to develop new technologies to use, and then also trying to test those out going forward. One advance that we've developed really quickly has been called this thing that we call the virtual annals platform. And what this is essentially is a cloud-enabled sort of capability where right now it's CDC and USG folks can actually use this platform. It's to actually do high performance computing for modeling capabilities. And so we did it as a pilot just to kind of like start thinking about how to actually enable our team to actually use these capabilities and not have to provision, if within the federal government to provision somebody a high performance laptop can take several months. So we were trying to sidestep that by using a cloud-enabled system so that they could just, like, if they need more computational power, they just say, it's like, okay, click, click, click. Okay, they got more computational power and they can run their bigger forward. We just have to provision it in different ways. And so this is the platform that we've started piloting to use with our team to actually be able to scale the computational power as needed. The thing that's been exciting about this pilot, though, is that during MPOX, there was the STI group within CDC, they were running some models that on their government issued laptops, high performance laptops, that they couldn't actually compute. They could do it, but it took several days for them to run because it was a fairly intense computational model that they were trying to do. They asked if they could port those models over to our environment. We said, of course. They ported them over. We could portion more computational power. They could run those within tens of minutes, whereas it was taking days before. And they were actually able to get results for MPOX to support the incident manager during a time of crisis. So it was, even in a pilot stage, this capability was allowing people to actually move much more quickly in decision making. Also, it's like our colleagues at the Administration for Strategic Preparedness and Response within HHS, they were doing some COVID models to actually give scenarios going forward over the next 3-4 months, and they do this on a monthly basis. They similarly had a laptop that they got run over by a bus or something like this, and they wanted to port it over to ours, and so we did. And they now run theirs on our pilot in an expeditious way as well. This is just another example of how we're going to try to build infrastructure to do this. Now, the real intrigue, though, too, is that what we're going to try to attempt moving forward is we're going to try to attempt to be able to make this environment available for our colleagues at the UK Health Security Agency as well, because we would love to be able to co-create models and work with them in some capacity. There's other sort of cybersecurity issues that we're working through to make that happen, but that's where we're driving to. So we can have a common operating platform to work with other colleagues in other countries, especially in a time of crisis. So this has been very, very fun. And it's one of those things when you're in the private sector thinking about using cloud-enabled services seems just natural. It's just what you do to build a company, but it's actually fairly revolutionary within government. Now, this is the thing that we just announced this week, and we just had kicked off this week. This is a network that we're referring to as InsightNet. Now, the reason that we call this InsightNet is because we want people. This is a group of individuals that we have funded 13 different awardees across the United States to actually help us develop, test, and deploy modeling capabilities to help improve our ability to actually use analytical insights for decision making. We named it InsightNet because we wanted everybody that's participating in this network to be focused on the objective of what we're trying to accomplish with the network, and that is an operational objective. We want to be able to generate insights that will help during a crisis, during a health emergency. We're not doing modeling for modeling's sake. We're not doing modeling to generate good science. As important as that is, we're using science in pursuit of our operational capability. And so that's what we're laser focused on. Now, there's three buckets of groups here: the innovators, the integrators, and the implementers. So the innovators, there's like 5 different groups within our network that are focusing on developing new models, new methods, looking at different types of data, like wastewater or syndromic surveillance, or even the digital data, contact structures and things like that. They are coming up with new ideas and how we're actually going to innovate and move things forward. The integrators here, they have to work with health departments in testing out those innovations. Are they fit for purpose? Are they actually helping us make decisions faster, make decisions better during a time of crisis? Is it going to help that state official make decisions in a different, more effective way? So we're going to test things out there, and things that occur that succeed there, we're going to move over to the implementers. What their job is going to be is how do we take these really good ideas and spread them to other jurisdictions that are not a part of our network, so that everyone has access to these tools and can use them and be able to actually move forward. Going, we have, like I said, 13 awardees. It's about $3 to $6 million per awardee per year for 5 years. That all rolls up to just north of $250 million. This is a huge investment by the federal government to improve this capability going forward. I think that we're taking a massive step in terms of not only building better capabilities broadly, but we're also taking a huge step forward in being able to work very closely with our state and local partners in actually using these tools to keep people safe. The thing that's very exciting about this, though, too, is these numbers right down here. There's over 100 network partners underneath these 13 primary awardees. 22 states are included, and at least 35 health departments are engaged in the network right now. Now, that's not all the health departments in the federal government or in the United States, but it's a lot of them. And so we're really excited to see what's going. This just launched this week. We're excited to see how this moves forward, how this goes into production, and how we see it realize its full potential. So I'm very, very excited. Now, this is my last slide, and I'll stop here. But this is a slide that my friend Jeff Shaman at Columbia University gave me. Wilmot knows Jeff. But essentially what this is time on the x-axis, and it's some measure of forecasting skill on the y-axis. And you see the monotonic increase in both forecasting skill through time for numerical weather forecasting. So the things that you can take away from this, though, too, is that it's like, this is the 50s and 60s, okay? In short, we were terrible at numerical weather forecasting back in the 50s and 60s. It was almost as good as putting a rock out in your front yard and saying, is it wet? And then if it was wet, then you knew it was raining, that sort of thing. But we've got progressively better at moving things forward, to the point that we all have mobile devices. Before I came here from Washington, D.C., I figured out, it's like, I need to bring my vest because it's gonna be a little bit cold. We all use it to make decisions on an ongoing basis. And in fact, the weather in Washington, D.C. is a lot nicer than the weather it is here. It's a lot cooler, a lot warmer. And so it's we also make decisions based on where we are in a hyper-local way. And that's all because what we've done to actually have this monotonic increase is we have invested in data, we have invested in computational power, we have invested in the people and the models, and we've sustained that investment through time. That's what allowed us to actually do this. Now, I will not try to tell you that we are here in infectious disease forecasting. We're probably somewhere right in here. So we're in the earlier stages of how we actually do this work. And then more importantly, how we operationalize this. Also, we're in the early stages of people having an intuition of how to use that information. You all understand, if you see it as an 80% chance of rain tomorrow, you know how to use that information. If you're going to be outside all day, you know what you start thinking about what you're going to do to kind of protect yourself. If it's an 80% chance of rain in 2 weeks and you have a major event, you're not going to pay as much attention to it, but you're going to kind of keep an eye on it. You've built up intuition on how to use that information and to make your own decisions based on it. We need to build the capabilities. Now we also need to build up the intuition of how to use that information for infectious diseases to keep ourselves safe, to keep our family safe and to keep our community safe going forward. The reason that I like using this slide, though, is because I do believe that we are at a transformative time in public health. We have definitely seen the need from the pandemic, from mpox, now from some of the challenges that we're facing in other infectious diseases. We have seen the power of data in efforts like the COVID tracking project, Johns Hopkins efforts that were done to bring data to people to be able to help them make decisions. We've also have the resources. I mean, Beth, I will, thank her to my undying days, because she was critical in getting the resources to actually get this moving forward. And we have tools, leadership, and a team that's trying to implement this going forward. We are at a transformative moment to actually make a big difference and to build capabilities that will allow us and our kids to have a different world. Now, I have a 7-year-old, and he is, my day rises and sets with him. He's, the central organizing principle of what happens in my life. And the thought of being able to build something that will make his life even better going forward is one of the reasons I get out of bed. The colleagues that I work with at the CDC are committed to that type of future as well. That's why I'm so proud to work with this team. It's one of the best I've ever worked with. I'm so proud to be able to work with colleagues at the CDC to actually make this a reality going forward. And I'm so grateful for the opportunity to be with you today to talk to you. Thank you very much. I appreciate your time. Yeah.
Well, thank you. That was awesome. And thank you for all your work. Picking up on your weather slide. So weather and infectious disease are very different. And the former is not impacted by human behavior on a small scale.
Yeah.
How are you thinking about your model and nowcasting forecasting actually being like an intervention and changing human behavior in real time? Does that factor in? Is it negligible? And how do you like the Hawthorne effect kind of thing?
Yeah, it's a great question. I mean, before the pandemic, I would have said it's like, wouldn't it be great if we could be in a position where people would actually use the data and it would affect their behavior so that we could actually change a pandemic but we started seeing it during COVID to some effects. So now it's like probably the analogy that probably makes more sense than weather is probably traffic forecasting, because it's very similar, complex dynamic interaction as well, where, it's like if one road gets clogged, it makes another road more viable going forward. And so we need to have sort of a complex adaptive kind of framework to think about this, because, humans, will throw everything off. And then also we have to confront this kind of like counterfactual. If we say it's like 80% chance of rain tomorrow or 80% chance of we're going to peak in cases, but then everybody sees that and gets really worried and stays home, does that mean the forecast was wrong? And so we're going to have this kind of like, how do we actually communicate? I haven't quite figured out how we actually communicate that. It was like, oh, well, that information helped everybody kind of be armed with information to protect themselves and their families. And then because of that, the forecast then became wrong. I think that's going to be a challenge for us, to be quite honest. And we don't know how to actually counter that effectively.
I guess a related thing, do you think it should it be in the background or mainly like facing systems, or should this be information like at are we all the consumers? Who's the consumer of the information?
Yeah, I think it's, I'm the type of person that I think should be as transparent as open as possible, and that people can use it to make their decisions. That's the world that I would want to live in, where it's like, you don't have somebody trying to interpret the Latin for the populace, but rather it's like, it's just out there. And the other reason I say that though too, is because I think that there's going to be a lot of smart people out there that are going to help us improve what we're doing. And point out errors, and we're going to try to embrace them as we can. But yeah, that communication problem is going to be really challenging. I mean, there's other professions, like in the intelligence community, economists, they all do the same sort of thing, where it's like they have to deal with pesky humans and how they're actually making forecasts about what's happening. So there's other places where we can look to kind of like get some analogies to kind of like move this forward. But especially in an era of information, disinformation and misinformation, it's going to be, I think, doubly challenging trying to make sure that message gets out. Yes. I don't have a good answer for that, but it's definitely something I worry about. Yeah.
So Dylan, so a group of us have been doing work on vaccine take-up in developing countries, in South Africa, Zimbabwe, and so on. Just to affirm the importance of localizing information, is that people who came late for vaccine, we asked them why, and so on and so forth. And they were most interested in being persuaded by what happened in the next neighborhood, the city of Cape Town. They didn't care about what happened in New York. So localized information is really important for persuading people vaccine take-up. But that meant that we then had to create a data collecting system for that. And then if you think South Africa is one thing, but let's imagine we do it in Gambia. This is a low resource society. How do you create a data system in low resource settings? So my question to you was, how are you going to network your center globally? And how are you going to deal with that particular question? I mean, it's not your issue, but it takes a lot of money to develop what you just did.
Yes. No, and you know, I think that it's a really important question too, because I mean, there's always the panic neglect cycle, and funding reflects that as well in terms of when we're going forward. You know, I do take part with certain other efforts. There's this thing called like the Malaria Atlas Project that was run out of Oxford. One of the things that they did there was really for malaria. It's like there was like a couple different studies that were done to understand the incidence of malaria in different parts of Africa. But in other places in Africa, it wasn't done. And so they came up with some really interesting efforts to actually use, you know, different sorts of really cool modeling sorts of approaches, you know, like Bayesian geostatistical approaches that were actually able to kind of like infer in places where they didn't do those studies from places where they did. And how do you actually essentially smear those results over a geography to kind of like give that hyperlocal information? So that one, I think there's some really interesting analytical sorts of approaches where we do have strong systems where we can actually, you know, inform other places that don't have as strong systems. So I think we need to explore those, you know, in a very full way. Number one. Number two is thinking about it's like one of the things the Malaria Atlas Project as well realized and found out is that one thing they're putting that information out, and it's actually very useful to the various ministries of health in their efforts to combat malaria. They all of a sudden realized like, hey, you can generate something that I couldn't generate on my own. I've got actually some more data that I didn't actually have out in the peer-reviewed publication. I didn't have out in the great literature. Can you take this and use it? And so they iterated on that going forward. It became this positive feedback cycle where they were getting more and more data because they could generate something that the ministries couldn't generate on their own going forward. Now that's hard. It's easy to say. It's a really good example to point to. It's hard to replicate. And it doesn't fully answer your question of how do we sustain the surveillance systems, which is the core basic function for some of these particularly low-income countries. But I do think finding those use cases where we can actually help people in a very distinct way has to be part of it.
Thanks for this. I really appreciate it, and congrats on setting this all up. In September 2014, I was in Guinea when the CDC, and you know, it kind of splashed all over ABC News and whatnot, was that we could have.
So your fault.
Yeah, my fault. It was up to 1.4 million cases of Ebola. Was that upper end of?
Yep.
You know, and I can't tell you like the profound operational, economic impact that very off number by like 1.37 million cases had, as well as like the impact it had directly on morale at that time, the folks I was working with. I'm curious, even if you don't know exactly how to do this communication piece, I wonder what the learning has been over that nearly 10 years in terms of like what things you need to avoid, even if you don't know exactly what to do correctly.
Yeah, and if you look across the trajectory of the major outbreaks over the past 20 years or so, it's like SARS-CoV-1, 2020, in 2003. Modeling and analytical capabilities like what we're talking about here had kind of no effect at all. I mean, it was like months later that great modeling work was done, but it was like months later. It didn't really inform what was going on in the response. You go to, you go to H1N1, the flu pandemic, and it's like, actually modeling was probably more of a distraction than a benefit. The people within CDC, particularly the CDC experience anyway in the United States, was they didn't have enough people internally within CDC that could actually even interpret the models very well. So it took a lot of time for them to actually talk to the modelers and figure, so it distracted them from other efforts. So I think probably it was a net negative. You go forward to Ebola, there were some good things that came out of those models, but there's actually bad things, as you pointed out, that came out of those models as well. The good thing that came out of that model from that 1.4 million, it scared the administration and it moved them. They rushed in more resources because of that model. But then, as you point out, operationally on the ground, it created a lot of frustration and it focused us in the wrong way. We were focusing way too much on the ETUs and the beds and not on other things like safe burials and other efforts. So it had good effects and it had bad effects. And so it was kind of a net neutral. Then you fast forward to COVID, it was clearly, there was bad things that happened with models, but the preponderance of benefit was pretty obvious. The key question though that you put forward, and it's a really good one, is how do we actually make sure that we're continually benefiting from the modeling and the analytical result insights versus distracting or taking us down rabbit holes. And that's going to be a question that we struggle with and that we try to improve upon going forward, because we know that it can be used for good and for ill. And so it's we want to be more positive than the negative, obviously, and that's what we're aiming for. But it is really hard to communicate these things and to make sure that they're understood effectively and that they don't have secondary unintended consequences. Yeah. So it's a great warning. Yeah. Thank you.
Thank you. My question is, so how would your center assess where to put assets? Obviously big things that have global scale implications are we're focusing on, but there's a number of outbreaks that are more localized, or affect some populations, SCIs and so on. Versus drugs and
Yeah. Yeah, thanks for the really important one. It's like you can think of us as a startup in government, first off. 2 years ago, we were 5 people. Last year, we were 20. Now we're about 50. We hope to build to about 100 people in the next year or two. And so we are slowly building our team. Over 60–70% of my team has only been on the job for less than 6 months. So we're really new. So because of that, we had to actually make really hard choices. Where do we focus our attention? In the early stages of where we focus our attention, it's going to be on acute respiratory diseases that could potentially cause great social disruption of some sort, or a pandemic. And so, so largely it's respiratory diseases that we're going to be focusing on in the early stages, and focusing on trying to provide analytical insights to the federal government in the early stages. But we want to quickly pivot to helping state and local jurisdictions within the United States and be prepared for responding to particular outbreaks. So that's going to be kind of like our near-term focus. We do have kind of like in our back pocket though too, we've been thinking about how we would build out a roadmap of how we would add new sorts of functions or new sorts of areas where we would start thinking about different sorts of pathogens. We're very interested in kind of sexually transmitted diseases. There's a really strong group at CDC already that does vector-borne diseases, and so we want to collaborate very effectively with them. And then also it's like there's lots of interactions between like chronic diseases that we need to really understand. What is the distribution of comorbidities in the United States so that when an infectious disease comes through. So we are starting to map out what our long-term kind of strategy is, how we think about other sorts of conditions that we could potentially do modeling on. But we are in the early stages trying to stay very, very focused on respiratory diseases that potentially could cause really acute social disruption. Yeah, but it's a great question. Awesome.
So, question for you is, what should we be teaching students to help you with your mission? what kind of skill sets?
Yeah, so I mean, and the way I'll answer that is like the people that we're looking for right now in the Center for Forecasting Operations, we're looking for data wonks, people that, I mean, reformed physicists, mathematicians, physicists that have now seen that they could do something meaningful with their life. We want applied mathematicians, we want, people that understand those sorts of issues. We want people that can actually that have experience in outbreaks. More importantly though too, and that's for the predict group. Importantly though too, we want people that have an understanding of modeling, but we also want people that communicate well. People that also understand policy and how to actually translate what that insight is into particular action. And so those are the kind of the purple unicorns, to be quite honest. I can write a job description, but I typically am finding purple or I'm finding unicorn. I'm not finding them both. And so it's really challenging because, we need people that understand the policy process and the response process. And we need people that understand, quantitative backgrounds really effectively. And then right now we need people that are just like dogged about and willing to kind of like jump in on anything and just kind of like learn. So yeah, those are the kind of people that we're looking for right now.
Well, thank you so much, Dylan.
Thank you, everybody. Appreciate it.